Welcome to the University of Kentucky Department of Anesthesiology YouTube channel. This videocast is entitled Anesthesiology Gaps in Knowledge and covers the years 2017 and 2018 American Board of Anesthesia Gaps in Knowledge. My name is Randy Schell. What are the gaps in knowledge? The American Board of Anesthesia publishes a list of topics each year after the annual in-training examination, and it's the main point, not the exact question, but the main point of questions that a majority of CA3 residents answered incorrectly. Now, this can be accessed at the ABA website at the address shown here. If you have an interest in watching a videocast on the gaps in knowledge from year 2014, 15, or 16, they're on our YouTube channel at the address listed at the bottom right. Let's move right in now to our gaps on the in-training exam 2018. The first gap was an increased temperature seen as the immediate result of a platelet transfusion is most likely due to the presence of cytokines in the platelet transfusion. This is describing a febrile, non-hemolytic reaction to a blood product where there's a rise in temperature of greater than a degree centigrade within 4 hours of transfusion, and the temperature goes back to normal within 48 hours. There's no evidence of hemolysis, such as hemoglobinuria, or a plasma that turns pink, or bacterial contamination. Remember that platelets are stored at room temperature and are the highest risk blood product for having bacteria grow in them. This febrile non-hemolytic transfusion reaction has been reduced by leukocyte reduction, or reducing the white blood cells in blood products. And it's also been reduced by the use of single donor apheresis of platelets. The next gap in knowledge is that facial and airway edema complicating airway management can result from ACE inhibitor associated angioedema. The picture up at the top right is a patient who received an ACE inhibitor, and you can see that the face, tongue, and if you could see the airway, would be very much edematous. This is angioedema resulting from ACE inhibition. Now, the classic is lisinopril being started in a patient after several doses, maybe even after the first dose. They start to develop this facial and airway edema. Occurs in about 1 in 1,000 to 1 in 200 or so patients that start the ACE inhibitor, and it's more common in African Americans. If you look at the graphic on the far right, you can see that ACE inhibitors inhibit the formation of angiotensin II from angiotensin I. The ACE inhibitor is inhibiting the ACE enzyme in the lung, and so angiotensin II levels go down. But the ACE inhibitor also inhibits the breakdown of bradykinin. In fact, the buildup of bradykinin is responsible for the hypotensive effect of lisinopril and other ACE inhibitors. But it's also the reason for the cough that's associated with lisinopril and other ACE inhibitors. And the angioedema that occurs as a result of a buildup of bradykinin can impair ventilation. It can result in severe airway edema requiring emergent intubation, awake fiber optic intubation, for example, or even a surgical airway. So if someone comes into the emergency room after recently starting lisinopril or other ACE inhibitor, realize that this airway edema can progress very rapidly, and establishment of an airway is critical, and usually in an awake format or even in a surgical airway. Gap number 3 is that the prolongation of the duration of action of succinylcholine can occur in patients who are taking donepezil. Now, donepezil, the other name for it is Aricept, and it is used by patients with Alzheimer's dementia. Aricept inhibits acetylcholinesterase, and it does so centrally because it can cross the blood-brain barrier, unlike neostigmine, and it does so reversibly, unlike ecothiolate, which are eye drops often used in glaucoma patients. So you can see that Neostigmine and ecothiopate also can prolong succinylcholine effect. But Aricept, because it inhibits acetylcholinesterase and also inhibits pseudocholinesterase, if it inhibits pseudocholinesterase, that is the enzyme, another name for it being butyrylcholinesterase or false cholinesterase or plasma cholinesterase. If it's inhibiting that enzyme also, which breaks down succinylcholine effects can be prolonged up to usually less than an hour. Now, if you're inhibiting acetylcholinesterase and acetylcholine levels build up, that competes with our neuromuscular blocking agents like rocuronium and vecuronium, our non-depolarizers. And so we may even need a higher dose of those non-depolarizers to maintain neuromuscular blockade in patients on Aricept. So you can see that Aricept interacts with depolarizing and non-depolarizing neuromuscular blocking agents, but the gap was that it can prolong succinylcholine. The manufacturer actually recommends that Aricept be withheld at least 2 weeks prior to scheduled operations. If you look at the graphic on the far right, you can see that Aricept 5 to 10 milligrams per day, classic dose. The red arrow showing acetylcholinesterase being inhibited. Acetylcholine builds up in the central nervous system and hopefully reduces some of the symptoms of Alzheimer's dementia. The next gap in knowledge from the in-training exam 2018 was that according to the National Institute of Occupational Safety and Health, the recommended maximal level for volatile anesthetics in the ambient air of an operating room is 2 parts per million. So I made the graphic at the top right showing desflurane, 2 little parts in the air around us in the operating room to remind you that the volatile anesthetics iso, desflurane, sevoflurane, when they're administered alone, we're not supposed to exceed 2 parts per million. Now, as a side note, nitrous oxide, when combined with a volatile, has a maximal NIOSH recommended maximal level of 25 parts per million, and there's a reduction of the volatile to 0.5 parts per million. But it's this 2 parts per million when we're administering one of our volatile anesthetics that we're not supposed to exceed in the ambient air around us. Now, it's important to realize that these are guidelines, and the National Institute of Occupational and Safety and Health wasn't able to really determine a safe level of exposure based upon the information at the time or even at the time now, and therefore the recommendation that quotes, the exposure be controlled to levels no greater than the lowest level detectable using the sampling and analysis techniques recommended by that NIOSH department in this document. So basically, our sampling levels, this is the maximal level at the time of the sampling levels, 2 parts per million is the number to remember of our volatile anesthetics in the ambient air around us. If you can smell the volatile anesthetic, you have far exceeded these NIOSH levels. Gap number 5 from 2018 was that an elevated ipsilateral hemidiaphragm is commonly encountered after deep cervical plexus block. Let's review cervical plexus blocks first. There is a superficial cervical plexus block and there is a deep cervical plexus block. At the top right is an example of a superficial cervical plexus block in which a needle can be placed at the central portion of the posterior belly of the sternocleidomastoid where the superficial cervical plexus comes out, and you can inject local anesthetic here as well as up and down the posterior belly of the sternocleidomastoid and block the superficial cervical plexus, which then the skin over the neck and part of the shoulder can become numb. It can be used for lateral and anterior neck surgery, for thyroid surgery and carotid endarterectomy surgery. But remember that if you were doing a carotid endarterectomy and you wanted to block the hemodynamic response to manipulation of the carotid sinus, you would have to inject local anesthetic around the carotid sinus to block cranial nerve number 9. And then the bradycardic response that can occur with manipulation would be attenuated. Now, a deep cervical plexus block is shown at the bottom right. And in this case, if you drew a line between the mastoid process and Chasnock's tubercle, which is C6, and that's at the level of the cricoid cartilage. And you went up and injected usually several different points along that line, C2, C3, C4, deeply, and you would then anesthetize the deep cervical plexus block, and some of the muscles of the neck would no longer be innervated during the time of the block. There's a risk of vertebral artery injection because the vertebral artery goes down at C6 and enters that space near there, and you can inject right into the artery. The subarachnoid space isn't far away, and the epidural space isn't far away, so you could get an injection there also. That is a risk. But in this gap, the gap in knowledge was that the phrenic nerve is near, and that phrenic nerve palsy with the diaphragm then being elevated on that side that was blocked is common after a deep cervical plexus block. And if you got a chest x-ray in this patient, the diaphragm on that side would be very high. So there's a recommendation that we don't do bilateral blocks on patients, or block a patient with severe lung disease who is very highly dependent on the diaphragm on that side. And if you knocked out one of their diaphragms, they may have severe respiratory distress. The last gap from 2018 was the mechanism of general anesthetics. Inhalational general anesthetics exert their effects by binding to amphiphilic cavities in proteins. Amphiphilic refers to hydrophilic and lipophilic properties of where these channels are. Now, in the past, the lipid hypothesis was taught as the mechanism of general anesthesia. That is, because there was a correlation between the potency and the lipid solubility of different anesthetics. The Meyer-Overton correlation was this correlation between the more lipid soluble an anesthetic was, the more potent it tended to be, and we could line those up. This suggested that there was a unitary hypothesis trying to explain the whole mechanism of general anesthesia with this lipid potency, lipid solubility correlation. But there is no single mechanism responsible for all anesthetics, and this unitary hypothesis is not true. And in fact, it appears that numerous proteins can interact with anesthetics with multiple ion channels being affected. So our volatile anesthetics are interacting, as the graphic shows on the top right, the general anesthetic in the light blue, interacting with proteins in membranes. And at these amphiphilic cavities in proteins, our volatile anesthetics are acting, and multiple channels are being affected. Let's move to 2017 now. The first gap in knowledge from 2017 was that successful placement of an adductor canal block will result in weakness of the vastus medialis muscle. Let's look at the picture at the far right. First, up at the inguinal region, you can see the normal anatomic relationship of the femoral nerve being lateral, then the artery, then the vein. So nerve, artery, vein at the level of the inguinal ligament. SA stands for the sartorius muscle, and then you have the muscles that are behind, iliopsoas muscles that are behind the femoral nerve, artery, and vein. The adductor longus is AL, and VM stands for vastus medialis, and the red arrow with asterisk is referring to the site where an adductor canal block is performed. The femoral nerve block obviously is performed up in the inguinal region. And a femoral nerve block is frequently utilized after total knee arthroplasty or before total knee arthroplasty to provide pain relief after surgery. And if you block the femoral nerve, you decrease the innervation to the quadriceps, which are the rectus femoris, big muscle anteriorly, the vastus lateralis, where I'm pointing now, the vastus intermedius, which is behind the rectus femoris, and the vastus medialis, which is represented by VM in this picture. If you decrease innervation to the quadriceps, the muscles of the anterior thigh are blocked, and strength is reduced, there's a risk of fall, there's delayed mobilization. So this is not a desirable thing to have. It would be better if we could just have the sensory blocked. So if you go down to the adductor canal, at the level of the adductor canal, represented by the red arrow, there's almost pure sensory block that occurs. At least that's the attempt for doing this instead of a femoral nerve block, to block just sensation. That is, the continuation of the femoral nerve is the saphenous nerve, which goes down the medial portion of the leg in the anterior portion of the medial malleolus and provides sensation below the level of the knee at very specific locations. So the femoral nerve continuation, there is some sensory innervation below the level of the knee via the saphenous nerve. Otherwise, the sciatic provides everything below the level of the knee. So if you block at the adductor canal, at the arrow, you can see that the femoral vessels are there, the saphenous nerve is there, and a nerve branch comes off the femoral nerve to the vastus medialis at that level. So if you block at the adductor canal, you may not get a blockade of many of the quadriceps muscles, but you will get blockade of the vastus medialis muscle. And the graphic at the right shows at the top under B, FN being the femoral nerve, lateral to the femoral artery and femoral vein, and that's where you would dump a local anesthetic for a femoral nerve block, as opposed to at the bottom graphic, ultrasound picture, C, SN is the saphenous nerve, FA is the femoral artery, FV is the femoral vein, and you would dump your local anesthetic next to the saphenous nerve, get sensory block in that distribution, but the nerve to the vastus medialis comes off, and you would get weakness of the vastus medialis, but not the other quadriceps muscles. The next gap, number 2, is that daily palpation of the dressing site for tenderness is recommended by the Centers for Disease Control as a method of preventing catheter-related bloodstream infections with central venous catheters. The CDC guidelines for prevention of intravascular catheter-related infections is at the website shown here, and I would recommend that you click on it and go to that website. But the recommendations include things such as, if you're going to put a central line in, it's best to avoid the femorals. There is an infection risk that seems to be higher in the femorals versus other sites. The catheter site should be inspected daily. You should palpate it. That was the gap in knowledge. If there's a dressing there, to see if it's tender, which would suggest that there was an infection developing, and inspect it if a transparent dressing is being used. And the central venous catheter that you're using, it's better to have a minimal number of ports, i.e. 1 or 2 ports rather than multiple numbers of ports. The more ports you have, the more chance of infection. If a central venous catheter was placed in an emergent situation and aseptic technique cannot be assured, that you should replace that catheter. Maybe it was placed down in the ED in an emergent situation very quickly. Sterility could not be assured. Replace the catheter within 48 hours. When you're placing a central venous catheter, use maximal sterile precautions, which includes a full body drape, cap, mask, and gown. And instead of betadine, use chlorhexidine prep. Don't put topical antibiotics on the site. And do not routinely replace catheters, i.e. Just replacing them every 5 days to try to reduce the risk of infection. And when I was in residency many years ago, it was not uncommon to use guide wire exchanges when catheters had been in place more than 5 days. The gap in knowledge, number 3 from 2017, is a somewhat difficult one, and that is that hypoalbuminemia, a low albumin, is a potential cause of metabolic alkalosis. Let's look at this concept of how a low albumin can be the cause of metabolic alkalosis. First of all, metabolic alkalosis is an increased bicarbonate and increased pH that can result from an increase in the strong ion difference that is commonly caused by hypochloremia or by a decrease in the concentration of total acids, which is caused by the hypoalbuminemia. Now, we need to think about that for a moment. If you put a NG catheter down and suck out the stomach, you're sucking out chloride and acid. You can see how someone could get metabolically alkalotic. If someone had a very low chloride, you could see how they could get alkalotic. And if we pour in sodium chloride in large volume resuscitation, saline resuscitation, with 154 milliequivalents per liter in 0.9 normal saline, you can see how you could get hyperchloremic, and with hyperchloremia comes a hyperchloremic metabolic acidosis that's associated with high volume normal saline administration. Let's get back to our topic now, which is how albumin can cause metabolic alkalosis. Well, if it's changing the strong ion difference, let's look at the definition of strong ion difference, which is the difference between the positively charged major molecules and the negatively charged major molecules, cations versus anions. And the strong ion difference is normally a positive number of about 40 to 44 milliequivalents per liter, and is calculated by the cations on one side, sodium, potassium, calcium, and magnesium, minus the strong anions on the other side, made up of chloride and weak acids. And the thing that is important to remember is that albumin is a weak acid. So if albumin is low, this difference, strong ion difference, will be decreased. And strong anion will be decreased, that is. The negatives will be decreased. And so the difference between positive and negatives becomes greater. And we must maintain electrical neutrality in the body. You cannot have more positive charges than negative charges. So if you're dropping the amount of negative charges, you have to find a way to drop the amount of positive charges. And it's water dissociation in our body that is creating and buffering against strong ion differences. So then there becomes a less dissociation of water to hydrogen ion, and therefore a metabolic alkalosis. It's important also to remember that anion gap needs to be corrected if there is hypoalbuminemia present. In fact, the anion gap can be corrected by 2.5 times a normal albumin, let's say 4, minus someone who's really hypoalbuminemic at 2. So 4 minus 2 would be 2, and 2.5 times that would be 5, meaning that our measured anion gap would need to be corrected by adding 5 to it if the albumin was low at 2. So hypoalbuminemia can result in an observed anion gap, which is calculated by sodium minus anions of chloride and bicarbonate. Usually we leave potassium out of the anion gap calculation. But if you added potassium in, it would be sodium plus potassium as the cations minus the anions, chloride and bicarbonate. But if albumin is low, it can mask the buildup of things like lactic acid, because as the lactic acid builds up, the albumin is very low, and so the anions are not building up as much, and you don't get that anion gap, and we need to correct our measured anion gap for the hypoalbuminemia. Miller, Anesthesia, 8th edition, has a reasonable discussion of this at page 1813 to 1816, and there's a good table there, 62, and I would advise you to go if this is difficult to understand for you and to review it. Our last gap in knowledge from 2017, gap number 4, was that the posterior cricoarachnoid muscles are solely responsible for pulling apart the vocal cords, abduction, and are attached between the posterior cricoid cartilage and the arachnoid cartilages bilaterally. So let's look at this. At the top right is a picture of the true cords, the epiglottis, the arachnoids, and the piriform fossa is on each side. That piriform fossa is where oftentimes our NG tubes can be caught, our TE probe can get caught up. If we put a fiber optic scope down and are off to the side, often we can see light on the side of the neck. Light wand, if it was put down and not midline, could end up in the piriform fossa, have light on the side of the neck. Vocal cords are closed, the picture at the left. Vocal cords are open at the picture at the right. And if we look at innervation of these muscles that open and close the vocal cords, all of the muscles of the vocal cords are supplied by the recurrent laryngeal nerve, which is a branch of the vagus nerve, except one, and that is the cricothyroid muscle, which is a tensor, pulls the vocal cords, tenses them a little bit, so that if you knocked out the superior laryngeal nerve external branch, which is the innervation of this cricothyroid muscle, the only muscle not supplied by the recurrent laryngeal nerve, a branch of the vagus, you would end up with a wispy voice, it's often called. You would not have a respiratory compromise, but have a change in your voice quality because you've lost the tensor, that tensor of the vocal cords. But let's get back to our gap now, which is that the posterior cricoarytenoids, represented by the red arrow and the red star, are shown attached to the cricoid and then to the arytenoids, and when they pull, you have to think of these little arytenoids functioning like a lever almost, and as the muscle of the cricoarytenoid pulls, it levers open the vocal cords, as opposed to the black arrow showing the lateral cricoarytenoids, that when they contract and lever on the arytenoids, they pull the arytenoids such that they rotate and pull the vocal cords together. So the important point here, according to the gap, is that the posterior cricoarytenoids open the vocal cords. But I'd also like you to remember several concepts related to airway innervation. First of all is that the gag reflex is cranial nerve number 9, that innervation on the upper part of the vocal cords is superior laryngeal nerve internal branch, and that's a branch of the vagus, and everything below the vocal cords is the recurrent laryngeal nerve, and that is also a branch of the vagus. And again, the innervation of the muscles are all muscles supplied by the recurrent laryngeal nerve, which also supplies sensation below the vocal cords, but motor innervation to all the muscles except that one, the cricothyroid, which is a tensor of the vocal cords. This ends the Gaps in Knowledge 2017-18. I hope that you have no 2017-2018 gaps in your knowledge now, and I also hope that you have a great day. Thank you for listening to our videocast.